It's only the 18th of November, and check out this nonsense. I'm glad I've gotten a head start on my facial scarf this year. Anyhow. It's a beautiful day in the beautiful day in the won't you be mine, won't you be mine, won't you be forever. It's an icy day in Canada, it's a snowy day in Canada, and it's only autumn, it's only fall. It's a beautiful day in the beautiful day in the I've been feeling like death these past few weeks as I fight a never-ending virus from hell. Thankfully, over the past few days, I've been coming back to life again a bit. But I do want to have a serious death-related talk today. Death in general is one of those important topics that we tend to avoid talking about, and that I think we should talk about a lot more than we do. The reason that I feel this way is partly due to my professional life, partly due to my personal life. In 16 years of paramedic work, I've dealt with dead people of all ages, from a 6-month-old to adults, both young and old. So it's something that I was constantly around at work, and then in my own life I've had a few experiences where I've come quite close to dying myself. But besides my own experiences with death, this is something that I'm really passionate about because of my own experiences also with pain and chronic illness. In fact, I'm kind of familiar with what it feels like to die from an illness. I've had Crohn's disease since I was a kid, and when I was 22 years old, the Crohn's stopped responding to the medications I was taking. As the months went by, I tried different medications, but I only got more and more sick, and the pain was becoming horrendous. I was in pain day and night. And while it was very clear that I needed to have a surgery done, I was putting it off and putting it off because I was in the process of trying to get a job in a different ambulance service from the one I was working in. So eventually, however, I put it off so long, and the inflammation in my bowels got so bad that they started to perforate, and I wound up having to be rushed in for emergency surgery. There was a 2-week process after surgery where I was in hospital for a week, had some major complications. The day I was released, went back for another week. By the time I was released from the hospital after that second week, I was a walking skeleton. I am 6 feet tall, I weigh 180 pounds. 2 weeks after that bowel resection surgery, I weighed 108 pounds, so 72 pounds less than I am right now. And the only realistic comparison I can make, and I hesitate to do so out of respect for these people, but the photographs you see where at the end of the World War people were released from concentration camps, and you see just how skeletal they are, that is exactly what I looked like at that point. And it was basically a coin flip whether I lived or died from that experience. And that wasn't even the worst pain I've ever been in. The worst pain was actually after my second bowel resection surgery, but that's a whole other story. So it's something that I am viscerally familiar with. It's just something that I have been through and know what it's like. And then going back to the professional life again, as paramedics, we would be called pretty much every shift into one or more nursing homes. Clearly, the elderly population are the ones who have the most serious health problems, so it's no surprise that the ambulances would be into the nursing homes regularly. And so often at work, we would walk into these places where there would be maybe 4 beds to a room, and just room after room of bedridden elderly folks lying there staring at the ceiling with an overwhelming stench of urine in the hallway as we walked past each of these rooms. And it's just one of those things where every time I walked into those situations in these nursing homes, my heart just broke for the people who were left there to be forgotten and die. And It even gets more insidious than that in some situations. I remember one specific instance where we were picking somebody up in an institution who was terminally ill, and the staff there outright informed us that the family was doing everything to keep that person alive because that person, as long as they lived, was receiving a pension from somewhere. So the family was getting money by this person remaining alive. So it was stuff like that that really turned this into such an important topic for me personally. Obviously, the specific topic I want to discuss today is physician-assisted death, or as we call it in Canada, medical assistance in dying. I was supposed to be interviewed on this topic for a podcast. However, the guys who run the podcast are pretty much the worst organized people you could ever meet, and it never did happen. However, I wanted to take all the research that I'd done and still put it out there because I feel very strongly and passionately about this particular issue. There are a number of different terms that can be used to describe this practice. Besides the couple that I mentioned just now, there's euthanasia and assisted suicide, and there are others. And here's the first pretty messed up thing. Apparently, the terminology actually makes a difference to people. A Gallup survey found that 70% of Americans were in favor of allowing doctors to hasten a terminally ill patient's death when the matter was described as allowing doctors to, quote, end the patient's life by some painless means. At the same time, far fewer than that, 51%, supported it when the process was described as doctors helping a patient, quote, commit suicide. So that 20% difference already shows you what sort of thing that I'm getting myself into here. So there's a term called dysthanasia, which means bad death. Dysthanasia occurs when a person who is dying has their biological life extended through technological means without regard to the person's quality of life. This happens to be the, I believe, skewed perspective of the modern Western medical model, where length of life is pursued at all costs, regardless of quality of life. So that's dysthanasia. The opposite of that is euthanasia, and it comes from Greek and literally means good death. So whereas dysthanasia is bad death, euthanasia means good death, although that word has kind of gone out of favor due to the negative connotations that sort of are hung on it now. We know that euthanasia was practiced as far back as ancient Greece and Rome at least, and it was actively supported by famous folks such as Socrates and Plato. The word euthanasia was first used in a medical context by Francis Bacon, as far as we know, in the 1600s, and he was using it to refer to an easy, painless, happy death, during which it was a, quote, physician's responsibility to alleviate the physical sufferings of the body. So early euthanasia techniques from the 1600s and on involved all sorts of things, from bloodletting to suffocation to taking people out of bed and placing them on the cold ground where it was assumed that that would cause instant death, or even something as weird as the sudden removal of a person's pillow, which they thought would accelerate death as well. Yoink! Go! Now, fast forwarding to the 20th century, in January 1936, King George V of England was given a fatal dose of morphine and cocaine to hasten his death. So basically, he was given a speedball to die. In 1972, here in Canada, suicide was decriminalized, and more recently, in June 2016, medical assistance in dying became legal in Canada for terminally ill adults. So although this has historically always been around, we're seeing it more due to a couple of recent changes in human history, I think. First of all, we're living long enough to die of cancers and Alzheimer's, dementia type things, whereas in the past, without the advances of modern medicine, a lot of illnesses would kill you very quickly, such as cholera or pneumonia or dysentery or anything for which we would give antibiotics nowadays. The second thing is that our way of life has changed dramatically in very recent history. Throughout most of human history, people have lived within small communities where there were family groups who lived very much together in a very close environment. Nowadays, we are so fragmented into individual houses and families, and when people become old, they're not with their families anymore. We don't give them the proper care that people at the end of their lives really need, which of course goes back to the nursing home issue I was talking about just now. So there's my 2 or 3 millennia of history in a couple of minutes. And now we're going to jump into the difficult stuff. And I'm going to take it step by step though. So I'm going to start with perhaps the least controversial aspect of it and gradually go step by step into deeper and much more difficult issues. As these increasingly complex and difficult topics come up, I'll also mention what countries in the world have legalized each of those steps along the path. So with step 1, I'm going to start with the basic pet example. So you have a beloved dog who has been increasingly listless. You take her to a vet where a significant amount of cancer is found in her body. And at that point, I think that a lot of us wouldn't have much of a problem with saying goodbyes and then taking her back to the vet where that dog could experience a peaceful and painless death. As far as I can tell, that is widely looked upon as an act of mercy and not necessarily a controversial thing. So that's the first and probably the easiest step. Now we're going to take a big step deeper now to go from animals to humans, and I'm going to ask the question, why do we struggle more to offer the same merciful and compassionate options to our own loved ones? Why would people fight against allowing a dying person to put an end to their suffering and to have a peaceful and a good death? As far as I can tell, the arguments against fall into a couple of main categories. First of all, there's religion, with the idea that euthanasia is sinful because it relates to suicide, which is considered, I guess, a sinful act in some religions. What seems strange about that argument to me personally is that the same people who argue that this is a sinful act are often the same to claim that their God is loving and merciful and cares deeply for all of us individually, which to me, these two ideas seem directly opposed to each other, that there could be a loving and merciful God who cares about us, but who insists that we ought not to shorten our own lives by even a minute. To which I would retort, but then anything we do to shorten our lifespan by even a day, like smoking cigarettes or eating fast food, should be equally morally wrong, should it not? But I don't want to dwell on that particular topic because arguing against religious ideology is such a futile exercise in the vast majority of cases. So let's move on to another of the major arguments, which is the slippery slope of society, which claims that opening this door of euthanasia leads to the slippery slope where eventually people are going to be forcefully euthanized against their will. From an evidential standpoint, I can assure people who have this concern that where euthanasia is legal, consent is integral to the process. There are no countries that have ever allowed it to happen without consent of the person involved. And where euthanasia is legal, there has never been an attempt to legalize non-voluntary euthanasia. There's never even been the tiniest step on that slippery slope to that conclusion. Even historically where this has happened, such as in Nazi Germany, which was forcefully euthanizing people against their will in the 30s and 40s, it was illegal in Germany to do this, but they were doing it anyhow. So in that case, the law had nothing to do with the practice that was occurring. At the end of the day, it's a throwing the baby out with the bathwater type of situation, except there is no bathwater, and there is no evidence to support that this could ever happen. The final argument against medically assisted death is that people will choose to do it for the wrong reasons. For example, someone who has a terminal illness fears that they are going to be a burden to their family, either a time and energy burden or even a financial burden if they don't have the proper healthcare coverage to take care of all the medical procedures that are required to keep them comfortable and so forth. Now, I do see this as a legitimate concern. The thing is, it's obviously a problem that's caused directly by healthcare and palliative care systems that are too often unavailable to the people that need them. What we really need to do is improve our health care, and especially we need good palliative care for those who choose to go that route and who decide not to have physician-assisted death. Of course, this is a vast problem nowadays with our rapidly aging society, with all the baby boomers reaching those elderly years, and we see the burden on our nursing homes, our palliative care institutions, all those end-of-life facilities are really overburdened and overwhelmed, and we're not giving the proper support we need to help people in that way. So that's how I myself would address those specific concerns. And if we look at the issue as a whole, the problem is if we don't have medical assisted death available to people, the other options are horrible. Either somebody has to potentially suffer terribly until the moment that their heart stops beating and their body gives out, or that person has to take it into their own hands and end their own life, which creates such a massive trauma for the survivors and whoever finds them. For example, thinking of work instances where I've dealt with people who have jumped in front of a subway or who have hung themselves. There's so many suicide scenes I've attended where either it happens in a public place, such as the subway, where you're traumatizing the operator of the subway and everyone who's witnessed it, or somebody who hangs themselves in their home, for instance, and who's found by a loved one, and what a awful sight that is, and what a trauma it is. I just think that that third option really needs to exist, so that these aren't the only two options available to people in these situations, and perhaps they do want to live as long as they can, and that's very okay. But if they have that option, then maybe they can not have to needlessly endure an incredible amount of suffering. Based on my own experiences, especially at work, responding to 911 calls in homes where a palliative patient is being taken care of by a loved one, for instance, I have a really hard time imagining that anyone who has been a lived-in caregiver for a loved one who has died of something like cancer would be able to find any moral arguments against medical assistance in dying. I believe that that very real, very hands-on lived experience really strips away a lot of the academic and philosophical arguments and makes it very real. So we're not even at the hardest part of these steps yet, but before I move on to the next complication, I'll just go over the legalities in various countries. So passive euthanasia, which is the withholding of treatment and allowing a person to die naturally, is legal in the US. Assisted suicide, on the other hand, which is utilizing the assistance of a physician to actually carry out the death process, is now legal in Canada, as well as in Switzerland and the states of California, Oregon, Washington, Montana, and Vermont. Interestingly, there are also independent organizations that peripherally assist people with the process of dying comfortably, such as the Final Exit Network in the US, that helps people obtain equipment and inert gases, such as helium and nitrogen, so that they can die in a manner similarly to inhaling carbon monoxide from a car, and to just physically be there and sit with the dying person during this process so that they do not die alone and have somebody to be with while it happens. So that's passive euthanasia and assisted suicide. Now, active euthanasia, which is the use of lethal substances or forces to hasten death, is legal in Belgium, Luxembourg, and the Netherlands. I'm not entirely clear on the difference between active euthanasia and assisted suicide. It might be the same thing. I guess I could have done some better research there, but anyhow, I am going to talk about the specifics of Canada's laws, but first we'll continue down this path of difficult decisions to areas that fall outside of Canada's laws. So for the third step, I'm going to ask the question, if we accept medical assistance in dying for incurable physical illnesses, what about mental illnesses? What about somebody who is actually disabled and suffering daily due to a mental illness that has not responded to medications or any other therapies? It sounds very wrong at first glance, doesn't it? But if we put some thought into it, I would say, why do we think less of mental pain and suffering than physical pain and suffering? After all, there's no way for us to objectively measure physical pain. We're always relying on an individual to tell us if their pain is unbearable or if it's something they can bear, and to believe what they say when we ask them, for instance, for a 1 to 10 pain scale. It's all an individual person's own experience that we're relying on and their ability to communicate that experience. So really, in that manner, it's no different from mental pain, is it? Now, this can become very challenging with specific mental illnesses, especially when it comes to the issue of informed consent. Does the person truly understand everything about the process, and is the consent they're giving based on a solid understanding of themselves, their illness, and everything that's happening? So I do think that it is an aspect of the topic that has to be seriously considered, and I think there's maybe even a place for it. It's just not as easy a thing as with an illness where you can look at a scan and see a cancer tumor, or you have other evidence of an illness that is happening in someone's body. Now, I was able to find 2 countries in the world that allow euthanasia for mental illness, those being Belgium and the Netherlands. Now, we've gone 3 steps down. This is the 4th and final step, and it is also by far the hardest, I think, from an emotional perspective. So what about children? It's certainly possible for a child to end up with an untreatable terminal cancer, for example. So how much will we make the child suffer before they die? As a father and as somebody who has handled dead children, this is immediately a very emotional topic for me. And it's a question that was actually hotly debated by Canadians in the 90s after Robert Latimer killed his 12-year-old girl Tracy, who was suffering immensely due to cerebral palsy, and he was subsequently convicted of murder, in fact. But when I read about Tracy's quality of life, about the incredible amount of pain she was in on a moment-to-moment basis, and the fact that she couldn't even take painkillers due to interactions with other medications and a seizure disorder that she also had, so they couldn't even treat the immense pain she had all day, every day. And when I saw the things that were being done to her by her medical team, the multiple surgeries they were putting her through, the various heroic measures they were going through to apply their Western medicine to her condition, it just made me so nauseous. I can completely understand why Robert Latimer made the decision to kill his daughter. There's nothing on earth that comes remotely close to the love I have for my wife and my kids. But if any of them were to end up in a similar state, I'd like to think that I could put the issue of their suffering and their quality of life above my own emotions and feelings towards them, and even maybe above my own liberty. It's such a difficult thing to talk about, even in a hypothetical situation. And child euthanasia is illegal in every country in the world except Belgium, where they have recently legalized it. And it is decriminalized under certain specific circumstances in the Netherlands, such as newborns who are born with spinal bifida or hydrocephalus. And in fact, the laws for regular active euthanasia in the Netherlands apply to everyone aged 12 and up. So that's certainly getting into the later childhood years there. Whew. It's not easy stuff, but like I said, I think it's very important to have the conversation at least. We're going to leave that behind now, and I'm going to look at the specifics of Canadian law and where we currently stand here in Canada. If you want to skip that part of the video, I will try to remember to put a link right about here-ish in order to fast forward to the next section. But like I said, here in Canada, the term for this process is called medical assistance in dying. Under Canadian law, a person may access medical assistance in dying only if they meet all of the following criteria. A, they are eligible for health services funded by a government in Canada. Basically, to prevent suicide tourism, it is available only to residents eligible for Canadian healthcare coverage. B, they are at least 18 years of age and capable of making decisions with respect to their health. C, they have a grievous and irremediable medical condition. More on that in a second here. D, they have made a voluntary request for medical assistance in dying that, in particular, was not made as a result of external pressure. And E, they give informed consent to receive medical assistance in dying after having been informed of the means that are available to relieve their suffering, including palliative care options. Before they can continue with receiving assisted dying, patients are required to be informed about what means are available to relieve their suffering, including palliative care options, to make sure that patients don't rush into the decision based on misconceptions or misinformation about what their future life may bring. Now, backing up to step C there, the law states that for a patient to have a grievous and irremediable medical condition eligible for assisted dying, they must meet all of the following criteria. 1, they have a serious and incurable illness, disease, or disability. 2, they are in an advanced state of irreversible decline in capability. 3, that illness, disease, or disability, or that state of decline causes them enduring physical or psychological suffering that is intolerable to them and that cannot be relieved under conditions that they consider acceptable. And 4, their natural death has become reasonably foreseeable, taking into account all of their medical circumstances without a prognosis necessarily having been made as to the specific length of time that they have remaining. When drafting the law in 2016, this last clause requiring death to be reasonably foreseeable has been controversial because it is a very narrow interpretation of the original Supreme Court of Canada ruling because it excludes both long-term disabilities and mental illnesses. So all of these conditions, as well as the fact that the patient is capable and willing of receiving a medical assisted death, must be independently confirmed in writing by 2 physicians and or nurse practitioners. It's interesting to note that Canada is unique in delegating the power of deciding medical eligibility for an assisted death to both physicians and nurse practitioners. It's a flexibility that was added in response to the concerns of rural areas, which often struggle with having a shortage of doctors. So I found it interesting that they were concerned about the access to physicians in the more remote parts of the country. So continuing along with the consent process, it is stated that due to the, quote, irrevocable nature of ending a life, end quote, to receive medical assistance in dying, patients must sign and date a written statement confirming their request to die in the presence of 2 independent witnesses 10 days before the day they will die. Patients must again give express consent of their wish to receive medical assistance in dying immediately before the actual process happens. And they must also be given an opportunity to withdraw their request immediately before the procedure is performed. This issue of having to sign and date a consent form 10 days before they die and then to verbalize their consent again immediately before the procedure occurs was an issue for one person who was involved in this process. Audrey Parker was a lady who died peacefully with medical assistance in her home in Nova Scotia just a few weeks ago, actually, on November the 1st, at the age of 57. Before her death, she was in the media explaining how these extreme consent rules actually shortened her life because she was afraid that if she waited any longer, a sudden change in her functional abilities might make it impossible to provide this written and verbal consent that was required and thus force her to endure a very protracted period of pain before her actual death would occur. She pointed out that there's a huge hole in the Canadian medical assisted death process, which is the fact that advance directives are not allowed in Canada for voluntary euthanasia. So patients cannot arrange to consent in advance to dying later in the hands of a caregiver, which for illnesses such as dementia and Alzheimer's, where patients may want to die after they reach a specific advanced state of mental decline, that is not in place for them. Rather, they would have to do it much earlier in the process if they could get the all clear to do so. This seemed like a major omission to Audrey and frankly to myself as well. Now, one country that does allow for advance directives, again, is Belgium. But staying in Canada for now, a patient who chooses to pursue medical assistance in dying can revoke their consent at any time, in any manner, without fear of consequences. In addition to this, the law also requires the patient to be informed repeatedly and clearly that at any time they have a right to refuse medical assistance in dying. So Canada's law is obviously more restrictive than that in Belgium or the Netherlands in that it does not permit minors or late-aged teenagers access to assisted dying. And it also does not allow assisted suicide on the grounds of mental illness. It's also not permitted in cases of long-term disability or any curable medical conditions whose only treatment options people may find unacceptable. In other words, Canada's law requires the presence of a terminal illness, while the law in the Netherlands and Belgium allows the euthanasia of people suffering from a long-term disability who are in lasting and unbearable suffering for which there is no other solution. However, in contrast to laws in states like Oregon that only allow assisted suicide if there is a prognosis of death within a 6-month time frame, Canada's law keeps vague exactly how soon a death must be reasonably foreseeable in order to qualify for assisted dying, keeping this matter of judgment up to individual medical practitioners. This also can be problematic because a doctor might decide that the actual death is too far away to permit the patient to go through with the procedure, but it also allows more flexibility at the same time. So, with all of this, you can see layer upon layer upon layer of safeguards and consent processes that we have in place in Canada. In fact, a Toronto doctor stated that only about 1 in 10 requests are actually granted, which sounds surprisingly low to me. If anything, the initial laws have leaned very heavily towards the safe side and away from the humane side, but I see it as at least a good starting point. Getting now into the specifics of the procedure itself, there are 2 types of medical assistance in dying available to Canadians. They each must include a physician or a nurse practitioner who directly administers a substance that causes death, such as an injection of a drug. This is becoming known as clinician-assisted medical assistance in dying, and it was previously known as voluntary euthanasia. Or the physician or nurse practitioner will provide or prescribe a drug that the eligible person takes themselves in order to bring about their own death. This is becoming known as self-administered medical assistance in dying and was previously known as medically assisted suicide or assisted suicide. As a result, we here in Canada take a step beyond the assisted suicide in the strict sense of the term, where a patient is administering the medication themselves that kills them. Canada's law is fairly permissive in this area, as it allows practitioners to carry out the act of euthanizing patients who want to die but who are physically unable to do it themselves. Regarding the specific drugs that are used, barbiturates such as secobarbital and pentobarbital have been popular. Pentobarbital has actually been widely used in animal euthanasia, but apparently I read that these drugs aren't nearly as widely available as they used to be because they don't have as many therapeutic uses as they did in the past. Now they're mostly used specifically for the processes of euthanasia in animals and humans. Based on what I read on the website canada.ca, there seems to be some flexibility as to which drugs or combination of drugs can be used for this. Which specific drugs to use are outlined in clinical guidelines and practices established by provinces and territories or organizations that regulate the practice of medicine. Many of the drugs commonly used for this procedure are already marketed in Canada and are prescribed at lower dosages for common purposes such as nausea, pain control, and anesthesia. As the regulator of drug products, Health Canada will work with partners as needed to help support access to drugs for medical assistance in dying. At least one doctor that I read about uses a combination of midazolam, propofol, and rocuronium. Midazolam is a very common sedative and amnesic drug. We actually use it on the ambulance to sedate people who were dangerously violent or who required intubation or whatnot. Propofol is another sedative and an analgesic. And rocuronium is a muscle paralyzer. It's the drug that actually causes death by paralyzing the respiratory muscles and stopping the breathing. It's interesting to note that Michael Jackson died of a combination of drugs that included 2 of those 3 medications, propofol and midazolam. What was surprising for me is that there also isn't something like potassium chloride given to stop the heart, that it relies solely on the rocuronium to stop the breathing and basically suffocate the person, although they're well sedated and unaware of what is happening, obviously. I just thought that there would also be something given in order to cause the heart to stop. And here is where I would like to let it be known that I want to die from King George V's cocktail of morphine and cocaine. I mean, it seems like the way to go to me. Alright, let's finish up this tough issue. Thanks for sticking through a difficult conversation with me here. It's just so damn difficult in our factionalized, clickbait-driven society to work through any serious issue. For instance, here are some of the headlines that I came across while I was doing my research. Legalized assisted dying is dangerous for disabled people. Why elderly should fear euthanasia and assisted suicide. Elderly to be euthanized under Obamacare? Canada legalizes euthanasia so parents can kill disabled children. I judge you unworthy of life, death, euthanasia. And this is why we can never have good conversations about anything important. Of course, the other larger societal problem that we face with this particular topic is our separation from death. We institutionalize death. We shove it into hospitals and nursing homes and funeral homes. We physically separate ourselves from it. And we no longer have that tactile experience with the dying and the dead that we've had for most of human history, where a person would die at home with family members, where the family members themselves would actually care for the body of their dead loved one. It's practically unfathomable to us now, although there are increasingly alternative and even more traditional options becoming available, such as with a death doula, or even just having the option of a person's body remaining at home and not being whisked off immediately to a funeral home. But since this is by no means common practice, as a result, most people just don't have the sort of very experiential, tactile relationship with death and dying that would show them just how important these issues are, and how these issues are maybe not as morally muddy that they would like to make them. I mean, we all have a terminal illness called life. We're all dying. Life is a very difficult illness for each of us in different ways. But I think it's very important for us to have individual autonomy over our lives and our deaths. I think that the most important thing is to equally respect a person's wish to live as long a life as possible, and to respect another person's wish to not experience undue suffering and to bring that to an end. In this instance, more options can only be a good thing. I think it's also very important to have these conversations with your loved ones and to make your feelings and wishes known to them long before these become immediate, emergent issues in your life. But I've been talking for a long time here. I do want to hear what you think. I want to carry on the conversation. And if you could let me know in the comments what your thoughts and feelings are, I'm very interested in hearing them. Are there any aspects that I have missed in this conversation? Does your own point of view differ from mine? That's totally cool. Let's show that we can have a respectful and thoughtful conversation, even on the internet. Hey, it's Josh. Thank you so much for watching. I'm really proud of the work that I put into making this video, and it would mean the world to me if you would take the time to share it with one or two people that you think might enjoy it as well. Cheers. Freezing in here. But the furnace off so there's no background noise, just so you know. Hope you appreciate my suffering. Yoink! Hey, there we go. Yoink! Fortunately, over the past few weeks... Yoink! But I do want to have a serious topic about... Yoink! So I'm going to start with perhaps the least controversial, although it isn't totally without controversies, since what do you call that? Yoink! Go! 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 Yoink! Go! I gotta look something up. One moment, please. Yoink! Go! What the hell? Go! 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 Oh! To use the slippery slip. Oh, okay. All of that for. And where euthanasia. Midazolam is.